resources, but also people that I personally don't know. You may know our speaker today, but by way of introductions, I'm Kara Janis, a postdoctoral fellow here in the center and co-coordinator of our seminar series with Dr. Melinda Rushing. We are delighted to have Dr. Kao-Ping Chua as our speaker today. Many of you know him very well. He is a primary care pediatrician, assistant professor, and health policy researcher here in the Department of Pediatrics at the Susan B. Meister Child Health Research Center. After completing his pediatrics residency at Boston Children's Hospital and Boston Medical Center, he obtained a PhD in health policy from Harvard University with a concentration in evaluative sciences and statistics. Dr. Chua's research focuses on opioid prescribing, out-of-pocket costs, and low-value care. And he was recently recognized with the Department Chair's Rising Star Award for his substantial contributions with his work to research and practice. So I will turn it over to Dr. Chua to introduce some of his recent work. He has, I think, some clear pauses in the sequence of the talk, so he'll open for discussion at that point if you would hold your questions. So then you're welcome to introduce questions into the chat, and Melinda and I will be monitoring throughout. Over to you, Kao.
About measuring and improving the quality of opioid prescribing to children and young adults. Next slide. I don't have any conflicts of interest to declare. Next slide. And I'm just gonna kind of go over three things today. First, I'm gonna review the importance of measuring and improving the quality of US opioid prescribing, both in general and specifically among children and young adults. Second, I'll review research that I've done on the prevalence, prescribers, and safety of opioid prescribing to children and young adults. And then finally, I will describe some work that I'm doing through my NIDA Career Development Award, focused on reducing excessive opioid prescribing after surgery in adolescents and young adults. Next slide. So really briefly, I just wanted to make sure that we were all on the same page about some terminology. So when we talk about the term opioid, I think it's important to define what we're talking about. So really, opioids are a family of drugs that include two classes of compounds. The first are opiates, which are naturally occurring compounds that occur in plants such as the opium poppy, and these include drugs like morphine and codeine. The second are synthetic or semi-synthetic opioids. Synthetic opioids are completely man-made, while semi-synthetic opioids are partially based on opiates and partially man-made. And these include drugs like hydrocodone, oxycodone, and heroin. Now, it's common to say that there is a quote-unquote opiate epidemic in the US, but that's actually a misuse of terminology, because that would actually imply that the epidemic of opioid overdose deaths is driven by morphine and codeine, when in fact it's actually being driven by synthetic and semi-synthetic opioids. Next slide. Now, opioids can further be classified as prescription opioids, which include things like oxycodone, versus illicit opioids such as heroin and extremely powerful derivatives of fentanyl, such as carfentanil. Prescription opioids can be further classified as short-acting opioids that typically wear off after 46 hours, which is the case for most opioids, versus long-acting opioids that have an extended duration effect, such as OxyContin. Next slide, please. So with that kind of basic background, I want to talk about why it's important to measure and improve the quality of opioid prescribing. So the first, so this argument really has three parts. The first is that opioid prescribing is common. The second is that it's associated with a high risk of adverse events. And the third is that it contributes to the epidemic of opioid-related overdose deaths, which many refer to as the opioid epidemic. Next slide. So this basically is national opioid prescription data from IQVIA between 2006 and 2019. You can see here that opioid dispensing peaked in 2012 at about 255 million opioid prescriptions, which was about the same as the number of antibiotics dispensed that year. And since then, opioid dispensing has declined a lot by about 40%. Next slide.
Kao, are you okay if we jump in with questions?
Can you hold those to the end of the section?
Okay, sure, I will.
Yeah.
Okay, I will.
Yeah. So it's declined by about 40%. Karen, next slide, please. So I think you went backwards. Yeah, there you go. No, next slide. Okay, so, but I don't want you to forget that despite this decline, don't let that fool you, because opioids are still one of the top classes of drugs prescribed in America. So this data shows the drug classes accounting for the most dispensed prescriptions in the US in 2019. Again, using IQVIA data, you can see that opioids were the #5 drug class in 2019 with about 169 million dispensed prescriptions, right behind antidepressants, antibiotics, cholesterol drugs, and seizure medications. Next slide. And recent data also suggests that the rapid decline in opioid prescribing in the US is slowing. So this is national IQVIA data that I just received about a week ago that goes all the way through December 2021. So between 2019 and 2020, opioid dispensing dropped from about 169 million to 156 million in 2020, but opioid dispensing in 2021 was 152 million, which is only 4 million less than 2020. So there's been a decline, but it's actually slowing, according to the most recent data. So next slide. I think you skipped one, sorry. Go back one. Okay, so in addition to being common, opioids are just inherently risky drugs that are associated with a variety of adverse events. So the basic problem here is that opioids have intended effects, which are pain relief and cough suppression, but they also have a variety of unintended effects, which include things, GI side effects such as nausea, vomiting, and constipation, as well as neurological side effects such as dizziness and fatigue. Opioids can also cause euphoria and physical dependence, the combination of which can contribute to the development of opioid addiction. And finally, opioids also have spillover effects in the sense that they can be diverted by others with access to the opioids, particularly family members and friends. And finally, and most importantly, opioids can cause overdose because they suppress the drive to breathe. And the risk of overdose is particularly high when opioids are taken concurrently with other drugs that depress respiration, which include alcohol and benzodiazepines, which are things like anxiety drugs such as Valium. Next slide. So the final reason to measure and improve the quality of opioid prescribing is that it triggered and continues to contribute to the US epidemic of overdose deaths. So this graph shows the number of US overdose deaths involving prescription opioids between 1999 and 2019. You can see that there was a rise between 1999 and 2011, a rise that tracked the rise in prescription opioid dispensing. And since 2011, there's been a plateau at about 14,000 prescription opioid-related deaths per year. Next slide. Now, 14,000 is a lot of deaths, but it's important to understand that there are many more deaths involving illicit opioids now, not prescription opioids. So this graph comes from the CDC and shows which drugs were involved in US opioid overdose deaths between January 2015 and June 2021. The first thing that you will see is that the number of opioid overdose deaths is at an all-time record high, with about 75,000 deaths in the 12-month period ending June 2021. You can also see that synthetic opioids, such as illicit fentanyl derivatives like carfentanil, which are the brown line, are involved in approximately 4 in 5 opioid overdose deaths. Prescription opioids include the natural semi-synthetic opioids in the green, as well as the methadone, which is purple. Collectively, these deaths, again, exceeded, were about 14,000 or so, which exceeded the number of heroin deaths, which is blue. But if you compare that to the brown line, it just really pales in comparison. So for some patient advocacy groups who oppose reductions in opioid prescribing, the take home from a graph like this is that decreasing opioid prescribing is simply not that important because they play a relatively small role in opioid-related overdose deaths compared with illicit opioids. But I believe that this is a misguided opinion because it ignores the substantial absolute number of prescription opioid-related deaths, which is 14,000 per year, as well as the many opioid-related adverse events that I just mentioned. More importantly, the rise in illicit opioid-related overdose deaths is not independent of opioid prescribing. The prescription opioids, these are the combination of the green and the purple. So it's basically, natural semi-synthetic plus methadone. Okay, so go next slide. So to understand the reason why the rise in illicit opioid deaths is not independent of opioid prescribing, consider this study from Cicero, which examined changes in the first drug of misuse among patients in treatment for heroin addiction. So in the 1960s, heroin was the first drug of misuse for over 80% of patients with heroin addiction. Between 2010 and 2013, when the study ended, about 1/3 of patients with heroin addiction started with heroin misuse, while 2/3 started with prescription opioid misuse. And a recent update of these data suggests that these trends are still continuing. Next slide. So the role of prescription opioids in transitions to heroin use was really well described in a great book called Dreamland by Sam Quinones, which I highly recommend reading. One of the key points made in this book is that widespread overprescribing of produced OxyContin beginning in the late 1990s created a cohort of patients with prescription opioid addiction. And over time, oxycodone became harder to get due to regulatory crackdowns. In response, some patients with opioid addiction started to use heroin, which was more lethal, but cheaper and easier to get. In other words, opioid overprescribing created a fertile ground for the epidemic of heroin-related deaths that occurred around 2010. Next slide. Now, what does this all have to do with the current surge in overdose deaths from illicit fentanyl derivatives? Again, fentanyl is the biggest culprit right now. I think the answer is really well summarized in this graphic from the Philadelphia Department of Public Health. The problem is that illicit fentanyl derivatives are now being used as an adulterant in heroin, in counterfeit prescription opioid pills, and in other drugs like cocaine. That means that when people try to buy heroin or prescriptions opioids on the street, some will actually unwittingly overdose on fentanyl derivatives, which are about 10,000 times more powerful than morphine. So in the short term, right, we can maybe mitigate some of this harm by distributing fentanyl test strips so that people can determine whether their drug is contaminated. However, in the long term, we need to prevent people from developing the desire to buy heroin and prescription opioids on the street in the first place. Because prescription opioid exposure is associated both with the transition to opioid misuse as well as the transition to heroin use, it follows that judicious opioid prescribing is a necessary part of achieving that prevention goal, although of course by itself it is not sufficient. Next slide. Now, lastly, I kind of, because this talk is about pediatrics, I want to talk about prescription opioid-related morbidity and mortality in adolescents and young adults. So in 2019, approximately 900 Americans aged 12 to 25 years died of an overdose involving prescription opioids, which is a rate of about 1 death every 10 hours. In many of these cases, of course, the prescription opioids belong to the patients themselves, while in other cases, the opioids were diverted for others. But still, despite that, these data still kind of highlight the importance of avoiding opioid prescribing to young people when possible, and to maximize the safety of this prescribing when opioids are required. Next slide. So in summary, opioid prescribing is common, risky, and contributes to the opioid epidemic. And for all these reasons, measuring and improving the quality of opioid prescribing remains a public health and clinical priority. Are there any questions at this point?
Yes, so a quick question. So on your earlier slide, Cal, where one of the first ones where you showed the 40% drop in the last 1 or 2 years, I think you showed something that kind of answers my question on a later slide, but how does that compare historically, even before? So that slide went from 2006 to 2021. Correct, but yeah. Do you have a sense of kind of where we want to get to? Like, is there any kind of sense of that?
It's still higher than it was in 2006, and it's
well, yeah, so we saw that, but
so I mean, I think we are at much higher levels than other developed countries for sure.
Okay, that's great.
And we're still even high by historical standards in the U.S.
Okay.
So the question is, what is the correct level of opioid prescribing? Well, the correct level is the amount that adequately balances the need to treat pain with, the need, to essentially get rid of, mitigate harm. And there's still, even despite the declines, there's still, I would argue, way too much overprescribing, and I can explicitly show that in some of the subsequent slides. that there's still just a lot of unnecessary opioid prescribing.
Yeah.
And then within the opioid prescriptions that are dispensed, there's still, like, the durations are often excessive. So there's still a lot of room for improvement.
Yeah.
Now, is there undertreatment of pain? Absolutely. And are there people who should be treated with opioids who are not being treated with it? Probably, right? There's some degree of that, but I think the bulk of the evidence is still pointing to overprescribing.
Yeah, and it sounds like other countries, might provide very relevant information for where that target point might be.
I think so, yeah. In Japan, for example, opioid prescribing after surgery is just not done, at least for most surgeries. Now, is that wrong? Well, I don't know. It depends on patient-reported pain scores, but I will explicitly address surgery if I have time at the end. Yeah, I know we started late.
Thank you. Great.
Skip over some things.
Related to surgery, I'm sorry. Maybe you don't want to address it, but I think that, like, a lot of this is due to different changes in prescribing patterns. I remember in medical school being taught that, you couldn't get addicted to oxycodone or whatever, and then obviously that's not true. But I also wonder how much of the changes in prescriptions have been driven in changes in the pediatric populations in the United States. Like, I mean, we, do more surgery on children than in other countries. I think, there have been increases in the perioperative population in the last decade. And then in addition, there's increases in the number of children who have chronic disease. And so I wonder, like, how much, like, what proportion of the prescriptions are attributable to changes, like sort of secular changes, like, in the population that we're caring for, and how much of it is just, like, bad prescribing behavior.
I mean, I think it's pretty clear that there's always been, there have always been a lot of patients in pain. I think that one of the big differences that, when pain became the fifth vital sign, which is honestly like a Purdue Pharma thing, that everybody promoted, watch Dope Sick if you want the background on that. It became this kind of mantra. Okay, so we need to adequately treat pain, and the way to do that is with opioids, right? It's particularly strong opioids like OxyContin, right? So I think it is almost like the changes that we saw all the way through 2012. That was a sea change in terms of how we thought we should be managing pain, both acute and chronic pain. Mostly it's chronic pain, but it was both acute and chronic pain. And then after 2012, everybody started to realize, okay, so maybe opioids don't work that well for chronic pain, or maybe there are other modalities. And oh, by the way, we're also seeing this epidemic of overdose deaths. So then there was like the opposite sea change, which we're going to try to bring everything back down. But of course, in the process, there was a lot of collateral damage. And I think that's where we are now, with the CDC trying to is actually revising its guidelines now, because there's been such an aggressive and unnecessary tapering, involuntary tapering, just pulling people cold turkey who have been on massive amounts of opioids. Like, you just can't do that. That was not the intent. So unfortunately, we kind of screwed ourselves by creating these patients who have dependence on opioids, and then all of a sudden we're like, oh, opioids aren't great, so let's pull it. And now we're in trouble, right? So my view as a pediatrician is, let's not start people on opioids unless we have to, because I think about prevention, right? So I don't want to deal with the chronic pain stuff. I know it's really important, but it's so messy. So to me, it's like, we're taking it.
Yeah.
The reason that pediatrics is so appealing is just that, it's usually an opioid naive population. So you can actually just isolate the problem. Should this patient get opioids or not? And if so, how many should they get?
Well, I mean, to speak to this just from an anesthesiologist perspective, I will say I came from an institution that was much more heavy-handed with the opioid use in the operating room and then in the post-operative area, and we use far less here. And I thought for a long time that maybe it didn't matter, that in the recovery room maybe our patients were getting all the opioids that we weren't giving in the operating room, and in fact that's not the case. And I think that's really interesting, and that a lot of this is just cultural, expectations about what recovery immediately in the postoperative period is even supposed to look like. So anyway, so thank you for addressing this. I'm sorry, that was more of a comment than anything else.
David, to answer your question, pediatric, I'm going to define as 0 to 21.
Thank you.
Okay. Let's move on. Next slide. So I'm going to talk about a paper that I recently did on the prevalence, prescribers, and safety of opioid prescribing to children and young adults, which again is the pediatric population, which is 0 to 21. Next slide. So this was published, this is a paper published in Pediatrics in July, along with Chad Bauman and Amy Bonnet from anesthesiology and my colleague Rita Conti at Boston University. Next slide. Just skip this. Well, okay, fine. Okay, the objectives were to essentially assess the prevalence of pediatric opioid prescriptions at the population level, to estimate the frequency of quote-unquote high-risk prescriptions that increase the risk of opioid-related adverse events, such as overdose, and determine which prescribers accounted for the most pediatric opioid prescriptions and high-risk prescriptions. Next slide. So this data that I used is the IQVIA longitudinal prescription database. Now this contains prescription level data from 92% of US retail pharmacies and the vast majority of mail order and long-term care pharmacies. In this analysis, I identified all prescriptions for opioid analgesics that were dispensed to US children and young adults aged 0 to 21 years in 2019. Next slide. So to calculate prevalence, I simply, essentially calculate the proportion of US children and young adults that had at least one dispensed opioid prescription in 2019. The numerator was the number of unique children and young adults with dispensed opioid prescriptions in the IQVIA database, and the denominator was just population denominators from the 2019 American Community Survey. Next slide. I created 6 metrics of high-risk prescribing. The first two assess the proportion of opioid prescriptions to opioid-naive pediatric patients that exceeded a 3-day or a 7-day supply. And the logic behind these metrics is that opioid-naive status is a surrogate for acute pain, which usually does not require more than a 3-day supply of opioids and hardly ever requires a 7-day supply. In this case, I defined opioid-naive status as the lack of opioid dispensing in the prior 90 days, which follows a quality measure used by the National Quality Forum. The third and fourth metrics assess the proportion of prescriptions to young children below age 12 that were either for codeine or tramadol, both of which are contraindicated in this age group by the FDA, owing to unpredictable metabolism. The fifth metric assessed the proportion of prescriptions to adolescents and young adults aged 12 to 21 years that had daily opioid dosages of 50 MME or greater. MME is a kind of a standardized measure of opioid potency. It stands for morphine milligram equivalents. The details aren't important, but 50 MME basically corresponds to 10 tablets of hydrocodone 5 milligrams per day. So it's a pretty high amount. The last one was the proportion of prescriptions to adolescents and young adults aged 12 to 21 years that overlap with the benzodiazepine prescription. And these latter two metrics were just based on previous research that I had done in a JAMA Pediatrics paper showing that daily dosage and overlapping opioid and benzodiazepine exposure increased the risk of overdose in adolescents and young adults. Next slide. And then finally, to assess the prescribers of pediatric opioid prescriptions, I first just kind of broke down opioid prescribing by specialty, and then I also essentially tried to characterize the distribution of opioid prescribing among prescribers. And to do that, basically what I did is I identified all prescribers accounting for at least one pediatric opioid prescription in 2019, and then identified prescribers with prescription counts in the 95th percentile or above. So we calculated the proportion of all prescriptions that were accounted for by these quote unquote high frequency prescribers, in other words, the ones with 95th percentile or above in terms of prescription counts. And then we calculated the proportion of all high risk pediatric prescriptions that were accounted for by pediatric high frequency prescribers. And finally, I just compared performance on 6 metrics between high frequency prescribers versus other prescribers. So next slide. So this gives you kind of a basic sense of prevalence and the characteristics of pediatric opioid prescriptions. So overall in 2019, there were about 4 million opioid prescriptions to children aged 0 to 21 years. These 4 million prescriptions were for 3.1 million unique patients. About 5 and 6 of them were for adolescents, young adults aged 12 to 21. 4 and 5 were for patients who are opioid naive. 3 and 5 were for commercially insured patients, and more than half were for hydrocodone. Overall, the median duration of the opioid prescription was a 3-day supply. Next slide. So so in terms of prevalence, our analyses suggest that about 3.5% of all U.S. children and young adults had at least one dispensed opioid prescription in 2019, including 0.9% of young children and 6.3% of adolescents and young adults. This proportion varied widely by census region, with the highest proportion in the South. The next slide, this table shows performance of the 6 metrics of high-risk prescribing. Among opioid prescriptions to the opioid naive, 41.8% and 3.8% exceeded a 3-day and a 7-day supply, respectively. Among prescriptions to young children, about 16% of them were either for codeine or tramadol. And among opioid prescriptions to adolescents and young adults, 11.5% had daily dosages that were greater than or equal to 50 MME, and 4.6% overlapped with the benzodiazepine prescription for at least 1 day. Collectively, 45.6%, or just under half of all pediatric opioid prescriptions, could have been classified as high risk by any of these 6 metrics. Next slide. So this table shows that dentists and surgeons accounted for about 38% and 23% of pediatric opioid prescriptions, or 61% of prescriptions collectively. And then the next most common prescribers were physician assistants, emergency medicine physicians, and nurse practitioners. Next slide. So when you look specifically at adolescents and young adults, the proportion of opioid prescriptions accounted for by dentists was even higher at 42%, compared with 38% in the overall sample, showing the outsized role of dentists in opioid prescribing to adolescents and young adults. Next slide. We also found that pediatric opioid prescribing is highly concentrated. Specifically, the approximately 20,000 high-frequency prescribers accounted for 53.3% of all 4 million opioid prescriptions in 2019, whereas the other 380,000 prescribers accounted for about 46.7%. And among the subset of opioid prescriptions that were classified as high risk, results were basically the same, with high-frequency prescribers accounting for 53% of high-risk prescriptions and other prescribers accounting for 46.9%. Next slide. When we compared performance on metrics, performance on each metric of high-risk prescribing, interestingly, the high-frequency prescribers did a little bit better on these metrics compared with other prescribers. However, the differences in general were not generally large, except for the 2 metrics on opioid prescribing to young children. Next slide. So basically what this, the take home here is about just under half of pediatric opioid prescriptions could be classified as high risk, according to one of the 6 metrics that we assessed. Specifically, about 2 and 5 opioid prescriptions to opioid naive patients exceeded a 3-day supply, even though many of those prescriptions were likely written for dental and surgical procedures that typically do not require long durations of opioid therapy. About 1 in 6 prescriptions to young children were for codeine or tramadol, even though these are contraindicated by the FDA. About 1 in 8 prescriptions to adolescents and young adults had high daily dosages, even though elevated dosages are rarely needed in this age group. And finally, 1 in 20 prescriptions dispensed to adolescents and young adults overlapped with a benzodiazepine prescription. Next slide. One of the key findings here is that dentists and surgeons have a particularly outsized role in pediatric opioid prescribing, accounting for about 60% of all opioid prescriptions in this age group. And importantly, there's a lot of evidence suggesting that safely reducing opioid prescribing by these clinicians is feasible. So for example, in some of my prior work, I found that 60% of children undergoing tonsillectomy receive opioid prescriptions, even though ibuprofen is equally effective for this procedure, particularly in young children. My prior work also indicates that 80% of dental opioid prescriptions to adolescents and young adults are written for tooth extraction, even though ibuprofen is an equally effective analgesic for that procedure. So now if you take that 80% and you multiply it by 42%, which is the percentage of all opioid prescriptions to adolescents, young adults that are accounted for by dentists, you come to the conclusion that almost 1/3 of all prescription opioid exposure in adolescents and young adults is for tooth extraction, again, for which ibuprofen is equally effective. And that actually results in about 1.1 million unnecessary opioid prescriptions per year. Next slide. We found that pediatric opioid prescribing is highly concentrated among a group of about 20,000 prescribers who accounted for 53% of all prescriptions. Now, importantly, this does not necessarily imply inappropriateness. It doesn't necessarily even imply a high rate of prescribing. So for example, if you're a surgeon that has a higher than average case volume, you could be a high frequency prescriber, even if your rate of prescribing is average compared with other surgeons. That being said, our findings do suggest that the prescribing rates of high frequency prescribers may warrant more scrutiny on average. We also found that high frequency prescribers kind of similarly accounted for an outsized share of high risk pediatric opioid prescribing of pediatric opioid prescriptions, which means that if your resources are limited and you're trying to improve the safety of pediatric opioid prescribing, you might have the most bang for your buck if you target high frequency prescribers. But an important caveat to that is that a sizable proportion of prescriptions that were high risk were written by other prescribers, which suggests that ideally you would have both targeted initiatives that focused on the high frequency prescribers, as well as broad-based initiatives that are inclusive of all prescribers. Okay, next slide. I am just going to skip this just in the interest of time. Go to the conclusion. Does anybody have questions about that study?
I'm just gonna, will there be time for you to help us imagine what these particular initiatives might look like?
Yes, I'm about to cover one.
Okay.
Okay, so I'm just gonna move on to the last section, which is really about quality improvement. Sorry, so next, go ahead to the next slide. So let me just kind of preface this by starting with this paper that was done by Hill at Dartmouth in 2016. And in this paper, basically what they did is they called adult patients after surgery and asked them how many opioid pills they actually took. Then they compared that to the amount prescribed and found that about 72% of opioid pills prescribed after surgery were unused. And actually, this was really one of the very first studies to describe this problem. And I would just kind of note that the publication date is 2016, which is kind of remarkable because that means that it was really only about 5 years ago that we really started paying attention to this problem of opioid overprescribing after surgery. Next slide. So on the basis of studies like this, people came up with a quote unquote revolutionary idea, which is figure out how many opioids people actually need after surgery and prescribe that amount. Now, I'm being a little bit sarcastic, but it's actually, again, kind of remarkable that it's taken us until the past 5 years or so to figure out that this is what we should have been doing all along, instead of sending people home with, for example, 90 pills of opioids for tooth extraction. Next slide. So here at University of Michigan, a group called Michigan Open, which is led by Chad Brumman, Jen Walge, and Michael Enklesby, they have been pioneering the development of evidence-based opioid prescribing guidelines for surgeries in adults. So for example, in a study of adults who had their gallbladders removed here at the University of Michigan, the investigators simply called patients 2 weeks after surgery and asked them how many pills they took. They then implemented a guideline based on the 75th percentile of opioid consumption. Now, before the guideline was implemented, 50 pills were prescribed on average versus 15 pills afterwards. Consumption before the guideline was an average of 3 pills versus 2 pills afterwards. And importantly, after implementation of the guidelines, there was no change in refills or in patient-reported pain scores. So what this study suggests is that it is possible to reduce the number of pills prescribed after gallbladder surgery without apparent harm, without apparent unintended effects, which is really kind of a rare win-win in medicine. Okay, next slide. Sorry, go ahead, next slide. All right, so over the past couple of years, Michigan Open has used a similar approach to develop prescribing guidelines for a variety of surgeries, which are listed here. So for the vast majority of surgeries, you can see that no more than 10 to 15 pills at maximum are recommended. It's only for major surgeries like total knee replacement, where the recommended number of pills is as high as 50. Next slide. Now, Michigan Open has actually leveraged one of the collaborative, the CQIs, the collaborative quality initiatives funded by Blue Cross Blue Shield of Michigan, to disseminate their guidelines to 76 hospitals across the state of Michigan. And in this, they published this New England Journal letter that showed that dissemination of their guidelines in October of 2017 was associated with about a 1.3 pill per month decline in opioid prescribing after surgery. Next slide. And they also found that dissemination of these guidelines in October 2017 was associated with a decrease in the number of opioid pills consumed, which is the black line. However, the trend for patient satisfaction and pain scores, which are the blue and the red lines, were basically flat. Again, consistent with the notion that you can reduce opioid prescribing after surgery without adversely affected patient-reported outcomes. Okay, next slide. So kind of an important limitation of the guideline-based approach is that it depends on clinician awareness of the guidelines. An alternative approach that I've been looking at that does not depend on clinician awareness is to gather evidence on patient pain needs by assessing patient-reported opioid consumption, then implement evidence-based dosing settings for opioid prescriptions written to post-surgical patients in the EHR. The hope is that the default settings serve as a subtle behavioral nudge that work in two ways. The first is that they are normative and that they tell the prescriber kind of what is expected. And the second is that they leverage inertia by allowing clinicians just to click through quickly, as opposed to just basically to click through, which saves them time. At the same time, these defaults are not restrictive, right? Clinicians can override them and prescribe a different amount if they want to based on clinical judgment, which preserves their autonomy and potentially increases their buy-in. Next slide. So in light of, so with that background, I'd like to now present the results of the first kind of aim of my NIDA Career Development Award. And in this study, I essentially wanted to evaluate whether an evidence-based default dosing setting in electronic health records could decrease opioid prescribing to adolescents and young adults undergoing tonsillectomy without causing unintended effects on things like pain control, essentially. Next slide. So the trial that I conducted was, enrolled adolescents and young adults aged 12 to 25 years undergoing tonsillectomy at University of Michigan. And I chose tonsillectomy simply because it's one of the most common and painful surgeries in this older population. Now, in the trial, I had two groups of patients. The treatment group included patients on the pediatric oto service who underwent, the pediatric otolaryngology service, and most of these patients undergo tonsillectomy at Mott. And most of them are also aged 12 to 21 years. The control group were patients on the general otolaryngology service who underwent tonsillectomy at University Hospital, and most of these patients are aged 18 to 25 years. Now, an important detail is that the pediatric otolaryngology service uses a discharge order set for writing opioid prescriptions, while the general service does not. Next slide. So this slide shows what the tonsillectomy order set looks like. So prior to my trial, the standard on the pediatric otolaryngology service was to write 30 doses of liquid oxycodone for adolescents and young adults aged 12 and up. Next slide. Now, in the trial, what we did is we collected data on patient-reported opioid consumption and other patient-reported outcomes, such as pain control, from October 2019 to December 2020, using a survey that we sent electronically to patients on postoperative day 14. In September of 2020, we decided to set the new default number of doses in the order set to 12. And we chose 12 because our baseline data suggested that 12 would cover the needs of more than 75% of patients. And we also chose 12 because it's kind of a weird number of doses to prescribe. And so we reasoned that a sharp increase in the proportion of prescriptions with 12 doses would actually signal adherence to the default settings as opposed to chance. So then we implemented the new default in the pediatric tonsillectomy order set on October 1st, 2020, only at Mott Hospital, where the pediatric service does its tonsillectomies. And then we collected post-intervention data through the end of July of 2021. Next slide. So this is what the new order set looks like. You can see that the new default number of doses is now 12 instead of 30. Moreover, the quantity of opioid dispensed auto-populates to 60 milliliters because each dose is 5 milliliters of liquid oxycodone. Otherwise, the order set looks exactly the same. Literally, this is the only change. We just changed that 30 to a 12. That's essentially what we did. Next slide. So next slide. So, no, I'm sorry, yeah. So basically we conducted 2 analyses. In the first one, we focused on outcomes that could be captured in the electronic health record, including the proportion of prescriptions that had 12 doses, mean number of doses, refills, follow-up visits for pain at University of Michigan, and follow-up visits for ER visits and hospitalizations at the University of Michigan. Next slide. We also did a secondary analysis where we limited to patients who had completed the postoperative day 14 survey and essentially evaluated the effects of the intervention on a variety of patient-reported outcomes, which are listed here, things like pain control, number of doses consumed, score on a depression scale, which is the PHQ-8, and validated patient-reported outcome measures from the PROMIS system on assessing things like sleep disturbance and anxiety. Next slide. Just briefly, the analytic approach here was a difference in differences analysis, where the treatment and control group was the pediatric versus the general otolaryngology service. As I mentioned, the pre-intervention period was October 2019 to September 2020, and post-intervention was October 2020 to July 2021. Just a quick note, we also had to exclude some data from March and April 2020 just because of the COVID outbreak. All right, I am just going to, because we only have a couple of minutes, I am just going to skip. Kara, can you just skip to the graph? This is the basic thing to take home. This is the proportion of prescriptions with 12 doses. And essentially what we see is that before the deployment of the intervention, very few prescriptions were for 12 doses on either the general or the pediatric service. But after implementation of the new defaults, the proportion of prescriptions that were for 12 doses spiked quite a bit on the pediatric service, which is the yellow line. And it basically did not change on the blue line in the general service, which is the blue line. And I'm just going to stop and I'll just tell you that essentially the rest of the analyses showed no effect on refills, no effect on any patient-reported outcomes except for a slight increase in sleep disturbance. So essentially what this is telling you is that you can basically just change the environment in which surgeons are operating, right? That essentially the environment for opioid prescribing, and you can make this very subtle change. And even in the absence of awareness of the change, people started prescribing the defaults. And furthermore, there didn't seem to be any sort of ill effects of that intervention or any sort of unintended effects on things like refills or on things like patient-reported outcomes. So the hope is that with a low-cost intervention like this, which can be readily scaled to a variety of other settings because everybody uses an EHR, will be able to hopefully become the new standard of care in opioid prescribing after surgery in pediatric patients. And with that, I will just stop, and I know we're out of time.
Yeah, we are at time, but if people have questions, I'm sure Kao, or I don't know if Kao has time, but if he does, we can stay a few more minutes. Thank you, Kao. That was a fantastic talk.